So AI-driven image acquisition and analysis for dementia diagnosis. AI is actually very important now in every step that we do. I have standard disclaimers, nothing added. We need an accurate diagnosis of dementia, and that's important because of the increasing importance in recent advances in treatment and imaging coverage by governmental entities. On July 6, 2023, Leqembi received traditional approval by the US FDA. And October 13th last month, CMS permits Medicare coverage for PET beta amyloid imaging by the Medicare administrative contractors. Those are the fiscal intermediaries in your area. We can use AI in every step of dementia diagnosis, and I'm going to walk you through what basically we do in clinical practice. We can assist dementia diagnosis by optimizing the image acquisition, both in MRI and in PET. We can actually also offer probabilistic determinations of dementia diagnosis. We can estimate the impact of future testing on disease probability, so clinical decision support in choosing what your next diagnostic tool would be. And we can quantify FDG PET results with AI compared to age-matched controls, offering probabilistic assessments of disease. And finally, recently in amyloid imaging, we have methods now, the centraloid method, for example, of quantifying your amyloid burden, so offering an objective assessment of disease burden. Why should we use MR quantification assessment of dementia? We're going to do an MR scan in a patient suspected of dementia anyway, so why not make it a volumetric scan? We can exclude treatable structural causes. And when we add volumetric studies, then we can also offer regional volume assessment, compare those to normal controls, and estimate their probability of dementia. These regional patterns of atrophy that we diagnose on volumetric imaging correlate with different neurodegenerative diseases. This is an example from the Galen 3T MRI. This is a volumetric 3D sagittal image of a 77-year-old with memory loss. And we can use AI to help us in image reconstruction. On your left is a standard image where we did not use any artificial intelligence support, and on the right is with ACE. You can see that we have the exact same time constraints on acquiring that image, but the image on the right has a much better signal to noise. When we look at MR volumetric analysis, we can acquire a lot of quantified data, including cerebral gray matter, cerebral white matter, but we can also get assessment of specific localized areas, such as the hippocampi, and look at regional atrophy scores, as well as cortical sulcal enlargement, to help us predict what type of dementia this patient may have. So we can look at cognitively normal versus Alzheimer's disease versus frontal temporal dementia versus a vascular dementia, for example, and we can then form a probabilistic assessment. And in this patient, we saw that based on their volumetric analysis, they actually have an 80% probability of Alzheimer's disease. Now, MR volumetric regional assessment does have strengths and limits. When we look at the hippocampi and the medial temporal atrophy scores, we find that's very good for distinguishing between Alzheimer's disease and normal controls. When we look at the anterior versus posterior ratios, that's actually very good for looking at Alzheimer's disease versus frontal temporal dementia. When we look at the white matter hyperintensities within the brain, that's actually predictive of the risk of vascular dementia. However, there are also neurodegenerative diseases where we have difficulty distinguishing them looking at volumetric studies. For example, there's really nothing good for helping us distinguish Alzheimer's disease from dementia with Lewy body disease on a volumetric scan basis. This is a 3T MRI using ACE, sagittal 3D flare. It helps us look at and quantitate the actual volume burden. And this volume burden is actually important in patients with Alzheimer's disease. And recently, last month, the etiology of white matter hyperintensities and autosomal dominant and sporadic Alzheimer's disease, we showed that these white matter disease actually is predictive of vessel amyloidosis, not their elevated systemic vascular risk. So the white matter hyperintensity burden we're actually seeing on these volumetric studies precedes the emergence of cerebral microbleeds, like we demonstrate on susceptibility-weighted imaging. So it is important to quantitate and identify white matter hyperintensity burden when we're looking at patients with neurodegenerative disease. MR interpretation and memory loss, we're doing many things. We're looking at cortical and lacunar infarcts. We're looking at those gradient echo SWI images for the presence of microbleeds. And we're trying to objectively calculate white matter disease. Right now, we use visual scoring systems like the Vesicus score. So if you're looking at the top, a Vesicus score of 1 is just scattered white matter hyperintensities. A Vesicus score of 2 is they're starting to become confluent in deep white matter. And a Vesicus score of 3 is they're confluent diffusely in the white matter. So you can see that I would rather use an objective assessment rather than just a visual assessment. But that AI quantification can be done, and we can look at the total number as well as the regional distribution using these AI-supported volumetric analysis tools. Now, after we've completed our MR volumetric analysis, we can actually use clinical decision support tools to help us decide what is the next test we should order. For example, in this patient, we look at the current, we see that they have about an 81% probability of Alzheimer's disease. But if we added CNS type cerebral spinal fluid, we could change their predictive value all the way up to 92% if they're positive and decrease it to 28% if they're negative. So this is actually using kind of an AI-supported clinical decision support analysis to decide whether you should do CSF testing. And I will note that the IDEAS trial proved that PET beta amyloid imaging is identical to CSF testing. So you could substitute those words in there and say that PET amyloid measurement could be potentially useful in helping confirm your diagnosis in the exact same way. FDG PET AI-driven image acquisition analysis also helps us in differentiating other neurodegenerative diseases. For example, AD versus FTD or DLB, for example. And PET image acquisition offers excellent image quality with up to 1 millimeter reconstructions now. AI-driven PET image analysis allows us to compare these to age-matched controls to assist in image interpretation. So this was an example of a 74-year-old male who presented with memory loss, mild executive dysfunction, and hippocampal loss on volumetric MRI. When we look at their FDG PET analysis, we see on the bottom right corner images, those are the 3D stereotactic surface projection maps looking from the medial portion of the hemispheres. We can see that there's conglomeration of Z-scores that are low in that medial parietal cortex. That represents the posterior cingulate cortex and the retrosplenial region. That's predictive of a patient that would have Alzheimer's disease. This is a 61-year-old right-handed female who presents with a non-fluent aphasia and language difficulties and difficulty reading. Images obtained on our Cartesian. And if you look, you can see that there's decreased FDG hypometabolism on that coronal image in the left temporal lobe compared to the right temporal lobe. And looking at that sagittal image, you can see that that is localized primarily to the superior temporal gyrus. When we use an AI-assisted 3D stereotactic surface projection maps, you can see on this bottom image in the left that those are Z-scores corresponding to the superior temporal gyrus. So this is the classic appearance of primary progressive aphasia. FDG PET image analysis, reconstruction, helps us when we're looking at distinguishing cortical gyri from white matter. And these are images obtained the exact same amount of length of time, but one image is processed using TOF PSF techniques and the other is using ACE. And you can see on the right the superior visual image quality compared to the image on the left, even though they're obtained the exact same amount of time. When we process these images in stereotactic surface space, there are now programs that let us do two different types of stereotactic transformations. The image on the left is doing a stereotactic transformation into a stereotactic space, for example, an atlas space. And the image on the right is when we translate those stereotactic images into the patient native space. The difference doing a native space transformation is that we can minimize partial volume effects and therefore improve our diagnostic quality. So you see that the images on the left showing hypometabolism or low Z-scores in those periventricular regions are not seen on the image where we do it in native space, suggesting that's usually artifact. And normally what I find that is due to is enlarged ventricles. FDG PET imaging has its limitations. It's challenging in early disease in patients that have subtle findings, and there's an inverse signal relationship of FDG with your disease process. There are potential confounding additive effects of copathology, and it does not address the need for treatment monitoring when we're looking at these new anti-amyloid therapies. PET amyloid indications are persistent progressive unexplained MCI, possible Alzheimer's disease with an atypical or mixed course, or comorbidities such as vascular, psychiatric, or substance abuse. Perhaps a patient has an atypical early onset, or if we're considering this patient for anti-amyloid therapy. This is an example of a 68-year-old female with short-term memory loss and a family history of Alzheimer's disease. And you can see that the radiotracer uptake is predominantly in the white matter and does not extend to cortex. But when we look at 3D SSP type of images, you can see that there really is no significant burden in the cortex, indicating that this patient is negative for beta amyloid. Negative beta amyloid is extremely useful for excluding disease. This is a 77-year-old male participant in the IDEAS trial with short-term memory loss, MMSE 21 out of 30, and an abnormal brain volumetric scan. And in this patient, we can see that there is increased binding of the radiotracer in the cortex. It extends all the way out. When we look at our 3D surface projection images, you can see that there's increased cortical radiotracer binding on these images from Combinostics throughout large areas of cortex and multiple lobar distributions, consistent with a patient with positive beta amyloid plaque. In addition, I really like that we can also calculate the centraloid value from this. The centraloid value is calculated by a ratio scale, generally from 0 to over 100, comparing normals to patients that have a disease burden of beta amyloid. But it allows us to do a amyloid objective assessment of burden despite whatever the radiotracer is. So in this patient, this centraloid scale that you can see region composite over 54 is diagnostic of positive beta amyloid plaque in this patient. The Cartesian amyloid PET imaging, this is a patient with reconstructed images at 2 millimeters on the left and the same data reconstructed at 1 millimeter. And look how well you can define the gyri looking at these 1 millimeter images. There is no other scanner that has 1 millimeter resolution in the market. So AI-driven objective amyloid burden, like for example through the centraloid measurement, offers a method of quantitating amyloid burden and can be measured over time. That's really important when we have borderline cases. For example, the IDEAS trial showed us that there was an 87% agreement with visual reads, but the variance was in those borderline cases. And when we use objective amyloid thresholds, I think we eliminate some of that subjective bias in these borderline cases. This is really important because in the IDEAS trial, we found that amyloid PET changes diagnosis in about 35% of patients. And the most important change is really when we had 25% of patients go from a diagnosis of Alzheimer's disease to non-Alzheimer's disease based on their PET amyloid imaging. Similarly, there was a 10.5% change in patients from a non-Alzheimer's diagnosis to Alzheimer's diagnosis after they received their PET amyloid scan. AI-driven image acquisition, clinical decision support, and analysis for dementia diagnosis is important through every step of the imaging process, from image acquisition in MRI and in PET. It allows us a probabilistic dementia diagnosis. It lets us have clinical decision support tools which estimate the impact of future testing on disease probability. And we can quantify and give objective measures of FDG PET results compared to age-matched automated controls like the Z-score analysis. And we can quantify amyloid burden like the centraloid method, allowing an objective treatment response measure. Thank you for your attention.